Hello. Here is finally the cardiovascular system, and I have a bunch more notes than what is on this PowerPoint, so I'm going to try and fill you in on all that. But yeah, I'll make sure all the important pieces are touched. But yeah, so I wanted to show you if I can get this to work. Not sure what that is. Um, this this is up um, on Blackboard. It's a PDF file. It's heart blood flow pathway. So you can kind of see where the blood comes in, where it travels, which way it travels. So when you're looking at this, know that the blood comes in first to the right atrium. Um, it comes in from the superior and the inferior vena cava. It goes into the right atrium, travels through the tricuspid valve, which is number 3, fills the right ventricle, where it goes up to the pulmonary artery and out to the lungs. So you can see kind of here, there's a right ventricle up through the pulmonary artery, and we're going to go out to the lungs and right here. So 6 is where we're going out to the lungs. There's going to drop off CO2 to be expelled, like when people breathe out, and to pick up some of the oxygen. It's going back in the lungs, coming in through the left atrium right here. From the pulmonary veins, because there's oxygen in the veins, and it'll fill that left atrium, then it'll enter the left ventricle right here. Fill that left ventricle. From the ventricle, it'll go up, it'll exit through the aorta, this big vessel here, this arcing one, and then out to the body from there. So here's, it also goes down here as well. So review that. That will help you understand a little bit more on how how it makes the anatomy of it. So anyways, like I said, I have, I think I've got 100 some slides that with all my notes on it. But yeah, this is just kind of the same thing as the picture that I drew. We're not gonna go over it since we went over that. This is, I know my first semester clinicals that we just finished up with, I'm pretty sure it was them. Yeah. We went over this of where to listen to the valves. So the right side between the second and third intercostal space, you will hear the aortic valve. If you go over to the left in the same spot between the second and third intercostal space, you're going to hear the pulmonic valve. If you move down to just about the bottom of the sternum, between the 5th and 6th, you're going to hear the tricuspid valve. And then if you just move over a little bit further, you're going to hear the mitral valve. So if you remember which one is which, you can have funny little sayings like the one without the apex in there is all physicians take money. So all for aortic, move over. P, physicians pulmonic. T, take tricuspid, and M, mitral money. So that kind of helps you remember where to listen for each of the valves. I don't think I have this. No, I don't have this in my notes, but when we are doing our cardiovascular system assessment, we want to look at what their past history is, what their recent history is. Um, Anytime there's questions, we can ask them about their peripheral circulation, color skin. Maybe the skin turns like kind of a ruddy or purple color. Maybe we can talk to them about their lifestyle or their endurance level. Their smoking, their drinking, their diet history is also a good one. Sleep history, lung sounds, because that will tell us a lot about how hard their heart is working. Medications they've been on either in the past or in the present. Obviously, we're going to listen to heart sounds, and obviously, we're going to do an EKG. So, troponin, these are all the common labs done for cardiac. So, troponin is the number one test that we want to see. This one is very sensitive, um, and it is specific to the cardiac. So when there's damage to those cardiac cells or the cardiac muscles, there's a protein that's left off or released, and that's the troponin. So anytime there's even minor damage to that heart muscle, the troponin is going to be elevated. Generally, it takes a little bit to go up, 4 to 6 hours, and peaks within 10 to 24 hours. Sorry about that. When you see troponins, generally they're going to be serial troponins until 2 of them are within normal limits. I think they're about every 6 hours apart. CKMB is, well, let's move down to the CK, the creatinine kinase. Anytime there's heart, brain, or skeletal muscles damage, the CK is going to be elevated. It's not cardiac specific, it's just the heart, brain, or skeletal muscles. Because when there's damage, those enzymes are going to be released, the creatinine kinase. A CKMB is specific to heart muscles because the heart muscles contain this MB isoenzyme. Another one where it's going to raise within 6 hours and be normal within about 24 to 72. CKMB normal range is 0 to 7. So then myoglobin is one that is found in cardiac and skeletal muscle cells, but it is not specific to the heart muscle, it's not specific to the skeletal muscle, but it is 99% effective in diagnosing an MI. The myoglobin actually raises within an hour of an MI, and generally it's up within it's elevated for 18 hours after chest pain onset. The myoglobin is actually one that actually elevates sooner than the CKMB or the troponin. So the myoglobin might be done if the symptoms are just very, very fresh. A CRP, C-reactive protein. This just shows us that there's inflammation in the coronary vessels. Anytime there's even a little bit of inflammation, the CRP will be elevated, generally used to predict risks for heart attacks. It's very, very, it's highly sensitive. So, going back to the CK, like I said, I apologize. My notes I've got more extensive notes. Just an FYI, we have the CK, which just tells us that there's muscle disease or damage, not specific. But if we move over to like a CK MB, that tells us about heart muscle. A CKBB is damage to the brain tissue, and a CKMM is skeletal muscle. So there are different types. CK is just kind of the overarching one, and then There's different types. All right. So, um, invasive diagnostic studies. This just means that they have to go in. It's kind of like a procedure or surgery. Angiography, where they inject dye into the vascular system, and then they view it, looking for use an X-ray and look for any like blood clot formation, um, aneurysms, those types of things. Cardiac cath is they actually go into the cath lab and they visualize the heart's A and P to look for blockages. So generally, a person will have a cardiac cath done, and if there's blockages, they'll go in for a coronary artery bypass graft. After a cardiac cath, these folks are immobile for 6 hours after, just to make sure their blood clots. They go up through the groin area. Yeah. Also, echocardiograms are done, or an EKG stress test where they're running on the treadmill. So, preload is how much the heart is stretching before the contraction of the ventricles. So, how much is that heart filling? The bigger the volume, the bigger the stretch, and the greater the force is the blood pressure to make sure that that heart is emptying. Basically, what preload is the amount of force needed to pump effectively. Okay, go. Okay, go ahead. Vasoconstrictors help with preload. If we want to decrease the preload, we're going to need to decrease the fluid volume. So the more fluid volume a person has in their vascular system, the more blood volume, the higher the preload will be. Afterload is the amount of resistance to that ejection of the blood from the aortic valve into the aorta of the body, into the aorta and out to the body. Different things might affect it. So like vascular tone of the aorta, the aortic valve, if there's any stenosis, if there's any restrictions to the outflow. To reduce afterload, you're going to see things like ARBs and basically a vasodilator, so that the resistance to the left ventricle ejection is actually decreasing. That's how we decrease afterload. Just some pictures of preload and afterload. All right, so before we get into high blood pressure, we should probably talk about blood pressure. So blood pressure is the force of blood exerted against the vessel walls. So think of like a toilet paper roll. Whenever the heart pumps, it's going to stretch. So think of that cardboard piece, if it was able to, stretching out. And then when it relaxes, the vessels also relax. So that is the systolic and the diastolic. So the systolic is when the heart pumps and causes higher blood pressure. And then when it relaxes, it's the lower blood pressure. Things that regulate the blood pressure is the autonomic nervous system. The kidneys have a big, huge factor in blood pressure, and then also the endocrine system. So, moving on to hypertension. Hypertension um, is basically an increased cardiac output. So the amount of blood that is ejected from the left ventricle in 1 minute is what cardiac output is. When you have high hypertension, it actually is um, more than what is normal. So when we have a patient that has um, decreased cardiac output, we want to look at their mental status. They might be disoriented. A lot of times they're going to have chest pain with walking, only because their body's not getting the oxygen they need to. So I kind of went off on a tangent there. So lifestyle contributions to high blood pressure. Um, if a person is overweight, they're at a higher risk for elevated blood pressure. I can't right now, honey. Go sit. Meal planning. Maybe they aren't running to McDonald's and grabbing the highest sodium burger they have. Caffeine and alcohol. Um, Exercise, getting on an exercise program. Smoking elevates the blood pressure because nicotine actually constricts the blood vessels, so it's harder for um, the heart has to work harder to get the blood to where it needs to be. Sodium or salt, and then sleep. If people aren't sleeping, their blood pressures are going to be elevated. Complications we see with high blood pressure: coronary artery disease. We might see atherosclerosis. Um, Stroke and heart attacks are common for folks with high blood pressure. Heart failure, because the heart just gives up. It's working so hard. So eventually it just does not work like it should. Kidney damage, eye damage, um, and hypertrophy of the right ventricle. But so what do? We need to find out what our patient's baseline is. Um, Baseline or average blood pressure that we would like is 120 over 80. But if our patients are generally sitting a lot higher than that, then we need to figure out what their baseline is, what's comfortable for them, what works for them. I know my aunt, I mean, it's elevated right now, but she generally sits 180 over 100 almost all the time. Education, we're going to educate them on diet, especially sodium and cholesterol in their diet. Teach them to exercise, get an exercise program going on, a sleep routine or sleep schedule, and trying to reduce some of that anxiety and that stress. All right, I'm going to pause here and run to the bathroom. All right, I'm back. So coronary artery disease is just a term that means obstruction of blood flow through the coronary arteries into the heart muscles. When blood flow is reduced to certain areas of the body, it causes basically ischemia, and that's what angina is decreased blood flow to the heart muscles, causing this pain, but it can actually lead to a heart attack if that blood flow is not restored. Basically, what it means is there's not enough oxygen going to the muscles and the tissues where it needs to be. Causes of coronary artery disease are atherosclerosis, where there's that plaque that forms in the arterial wall. Arteriosclerosis, where the arterial walls are actually thickened, they don't stretch as well, and they're actually kind of calcified. They turn kind of hard. Causes of CAD can be genetics. Diabetes mellitus is a huge cause for coronary artery disease. High blood pressure, which goes along with the diabetes, Smoking, which causes a high blood pressure, obesity, which causes all of the other above, sedentary lifestyle can cause CAD. So what we treatment for atherosclerosis is things like the statins, the cholesterol meds. So what atherosclerosis is these plaques. That plaque on the inner wall of the arteries is jagged. So that's the part that the blood passes through. So that plaque becomes hard, calcified. And think about a stream, when you've got a stream constantly going past, and the rocks will come loose, the dirt will come loose. Well, it's the same thing with atherosclerosis. Eventually, that plaque is going to let loose and break off. So the blood clot is going to form right there where it broke off, and can actually block arteries. Or that clot can break off and travel up to the heart or the brain and cause a stroke or a heart attack. So angina pectoris, there's more need for oxygen in the heart. So when the heart is working harder, it needs more oxygen to function. So when these vessels are narrowed from like coronary artery disease or arteriosclerosis, they're not able to get dilated because they're hard, they're not stretching, and so they can't carry more blood and more oxygen, which then will cause ischemia to the heart muscle, which is angina pectoris. Angina can be stable or unstable. And most people are going to define it as like a squeezing or kind of like a vice-like pain, or maybe it says they'll say, I'm tripping over my words today, that an elephant sitting on their chest. Sometimes it radiates, sometimes it doesn't. So just kind of stable angina. Now, I had a hard time figuring out what stable angina was. All I heard was angina. Sorry, I just took a bite of ice cream. Bad idea. So, stable angina is when a person starts to do some activity and they have chest pain. But this is familiar to them. So their pain's predictable. And if they take a nitro and they lay down, the chest pain will stop. Basically, it's predictable, familiar to the patient, and it stops when the person lays down to rest or when the activity is stopped. And nitro helps with stable angina as well. So when we're treating stable angina, we want to figure out what the patient can change. Can they change their lifestyle? So maybe they are a lumberjack. Might be very hard to change their lifestyle, but if they're doing all these activities out in the woods by themselves, it's probably not a good place to be with stable angina. Then we can look at things like their diet, their exercise, their stress levels, their cholesterol intake, what their cholesterol levels are looking at. Stable angina, like I said, you're going to see things like chest heaviness, chest tightness, squeezing, crushing down the center of the chest. They might be pale, diaphoretic. They might be maybe a little bit short of breath. They might even have that feeling of impending doom. Even though this is stable angina, it's going to present the same as unstable angina, but the difference is this is predictable. The patient can get it to stop on its own. Medications that we're going to see. are like vasodilators, like I talked about the nitroglycerin, and that's kind of a rescue med. And then isosorbide is one that they take twice a day, daily. Just depends on what their levels are. Because what that does is it dilates those coronary arteries, so that way they can get more blood flow, more oxygen into the heart tissue and the vessels, and they decrease the workload of the heart. So um, that actually decreases the pain. You might also see calcium channel blockers, um, because what those do is basically relax the smooth muscle. When there's calcium actually causes electrical excitability, so therefore it's firing off all these impulses. When they take calcium channel blockers, these impulses are blocked, so that they're not firing so much, and the heart isn't quite contracting as much, and the workload is decreased. Beta blockers, you're going to see things like metoprolol and atenolol, the OLols. What these are going to do is they're going to decrease the heart rate, they're going to lower the blood pressure, and they're overall going to decrease the workload on the heart, which overall decreases chest pain. With beta blockers, we need to be careful when we give it to people with like COPD and asthma, because they can actually cause bronchoconstriction. Moving on to the ACE inhibitors. These are things with the pril ending, the PRIL. What it does is basically blocks the production of angiotensin II. With these meds, the ACE inhibitors, the prils, a major side effect is a dry, hacky, annoying cough. Sometimes it is enough to the patient won't take the med, but sometimes it's just something they live with. But just know that a dry, hacky cough is a side effect of the prils. Variant or vasospastic angina. This is when that coronary artery spasms. Generally, it happens at the same time each day. Can happen exercise, at rest. Can happen at night. It's also called Prinzmetal's angina. So moving on to unstable. All right. Unstable angina is chest pain that does not get better with rest. It's changing. It's unpredictable. It's not familiar to the patient. So they can be out doing their lumberjack things, complain of chest pain. Oh yeah, usually when this happens, I sit out in the truck for 20 minutes and it goes away. And the other day, this is when they're going to sit out in the truck for 20 minutes and it's still going to be there. They're going to take their nitro and it's not going to work. It's going to happen more frequent and it's going to be more severe. Generally, we don't see unstable angina until there's about 60% blockage. So it's very serious when we have this unstable angina. Unstable angina can actually be a precursor to a myocardial infarction, a heart attack. Basically, what an MI is death of the heart muscle, whether it's blocked, whatever's going on, but that heart muscle is dying. That's what causes the pain. That's what the tissues and the cells are dead. Decreased blood supply. Maybe there's cholesterol blockage. Maybe there's a blood clot. Just depends on the location and the amount of how bad the blockage is. So people who are having a heart attack, they're going to take their nitro, they're going to rest, and it's not going to do any good. Heart attack can actually cause mimic a gallbladder attack or indigestion or anxiety. So all four of those kind of have the same type of symptoms. Things we're going to see are shortness of breath, nausea, sweating. They might have abnormal lung sounds. Pain is going to radiate from their chest to their arm usually. Women sometimes have weird symptoms like stomach issues. So what we want to do is prevent that cardiac death. Now, in third semester, when you guys will be, it'll be fourth semester for you for skills. But when you start learning about EKGs, when you're looking at an EKG and if you see an ST elevation, that is a huge sign of a heart attack on the EKG. There's end STEMIs and there's STEMIs. When the person has a ST elevation, elevated MI, this just means there is a complete blockage. So, surgical management of coronary artery disease, because coronary artery disease is basically the cause of all these other things. We might see some percutaneous transluminal coronary angioplasty, basically so we can get more blood flow to the heart muscle. And most common that we're going to see is a CABG, a coronary artery bypass graft, whether it's a double, a triple, quadruple. In the picture here, it shows us that wherever the blockage is, there's actually a leg or a vein taken from the leg that actually bypasses the blockage, so we can get more blood flow to the heart muscle again. The CABGs are generally what we see when we see the open heart surgeries. All right, moving on. Peripheral vascular disease can be in the arteries, can be in the veins, either one. Generally see this more in elderly and definitely more in the diabetics. When we're looking at peripheral artery or peripheral vascular disease, when it's affecting the artery, they're going to have pain in their leg with elevation, or any pain in their calf when they're doing activities. If it's a venous cause, it's going to take longer to set in. Generally, they can be walking or sitting. It doesn't really matter. And the pain is more when the legs are dependent. So like when they're sitting in a chair and their feet are on the floor. So that's the difference between those two. Peripheral vascular disease is pretty nasty. People talk about nurses having toes fall off in their hands. I literally had a lady with severe peripheral vascular disease, and her toe fell off in my hand when I took her sock off. It was awful. All right. Arterial thrombosis and embolism. So, a thrombosis is a formation, the development, or presence of a blood clot in an area. Now, when that thrombosis, that blood clot, breaks loose and travels, it has now become an embolism. Eventually, it will get into a vessel that is too small, and it will cause an obstruction. It will occlude the blood vessels. So, things that we see the thrombosis and the embolisms, are anytime with like just arrhythmias, like AFib. The heart is not pumping effectively, so that blood is sitting pooling in the heart. So once it does get kicked out, there might be some clots in there that can travel to the brain or the leg or wherever. See it more with prosthetic heart valves, rheumatic heart disease. So if we're looking at a blood clot, we're going to see The 6 P's: pain, pallor, pulselessness. You guys that were in sim with me and had, or even the other groups that had Mick, this will make sense to you. Pain, pallor, pulselessness. So there's pain, it's pale or even red, that you don't feel a pulse below the blood clot. They might have paralysis. They might not be able to move that leg or area. They might be tingly and might have poikilothermia. So treatment for thrombosis, it needs to be treated right away. This picture is actually true to life of how it can actually look. So immediately we're going to get them on some type of anticoagulant, heparin, Lovenox, Coumadin, one of those newfangled ones. They might need to have surgery depending on how big the clot is. It's called an embolectomy or a thrombectomy, where they actually go in and remove that clot. I've seen it where the clot was like from the thigh all the way down to the ankle, and they had to go in and remove it because there was, if that sucker let loose, that person was going to not make it. So. I don't know. All right. Thrombophlebitis is formation of a clot, inflammation in a vein. It can be a superficial, it can be a DVT, either one. For thrombophlebitis to form, you need 3 different factors. You need the blood flow to be like stalled, the vein wall damaged, which would be like if a person had an IV, and then you need their coagulation to be increased. So they need to clot a lot easier. So you can see on the pictures here, that kind of tells you exactly what happens with the different types. Symptoms we're going to see, wherever that inflammation is, we're going to see pain, warmth, redness. Might see some venous distension, tenderness, edema to that extremity, redness. We also might see like a red line following the vein. Generally, to diagnose, we're going to do an ultrasound. Our treatment's going to be like, we're going to elevate the affected body part, whether it's in the leg, whether it's in the arm, whatever. Bed rest, hot moist compresses, stockings, wherever it is, we're going to put them in probably TEDs. We're going to put on anticoagulants, and eventually the body will dissolve that little clot. Peripheral artery disease is the chronic progressive narrowing of the arteries. So eventually it will affect how much oxygen and nutrients are delivered to the body. And when there's not enough oxygen, not enough nutrients, not enough sugar, there's going to be ischemia of these areas. Generally, the biggest cause is atherosclerosis. So, in peripheral artery disease, what we're going to see is intermittent claudication. This is pain in a person's calf when they are walking, exercise, doing an activity, and they get pain in their calf. It will stop once they rest and put their leg up, but it will be intermittent. Other symptoms we're going to see in PAD, when the legs are up and elevated, they might be pale, they might be blue or purple. When they're in a dependent position, like when they're sitting in a chair and their feet are down. They might also look like their skin like mottled. It'd be dry, flaky, scaly. Their toenails are going to be thickened, so you can look at a person's toenails and determine, yeah, they probably have PAD. And their extremity is going to be cool. It's not going to have as much circulation to it. So It's going to feel cool to the touch. Treatment for PAD is we want those vessels to vasodilate. Um, we might have them change their diet, not eat so much fatty food, not so much cholesterol. Things like um, blood or anticoagulants, and they might need surgeries. All right. Raynaud's disease is a disease, illness, whatever, primarily of the hands. Um, when a person gets cold, they have extra pain. Um, or no, when they get cold, the blood flow to their fingertips actually stops. So that's why their fingers are white in color here. Um, the arteries in the ends of the fingers are spasming, so they're not getting blood flow to them. It's very painful. Um, once the um, veins are done spasming, these the hands are going to turn bright red because there's uremia, or hyperemia. I can't talk. Um, because all that blood flow is rushing back to those fingers. So treatment for it is basically keep the hands warm and try and avoid anything that triggers the vasoconstriction. All the bad habits like smoking, drinking, caffeine, stress um, will actually cause exacerbations of Raynaud's. They might also be treated with vasodilators. Um, Symptoms of Raynaud's: those hands are going to be cold, they're going to be painful, and they're going to be pale. So, moving on to Buerger's disease. Um, this is inflammation and blood clotting of small and medium arteries in the hands and the feet. Um, generally or in males, um, can cause intermittent claudication. But the biggest factor of Buerger's disease is that they have linked it to um, smoking like cigarettes and smokeless tobacco like chewing tobacco. So can actually cause death in the fingertips like this because there's decreased blood supply. And yeah, that's exactly. I haven't seen Buerger's disease for sure, but um, I have seen dead tissues, and that is what it looks like. All right, aneurysms. This one here is a abdominal aneurysm. So um, anytime in an artery there's like a bulging, a ballooning, it's dilated or weak, um, it can actually bulge out and it'll thin out and eventually it can burst. Um, can be caused by atherosclerosis, hypertension, smoking, trauma. It does run in families. It might be something they're born with as well. So symptoms for aneurysms are pretty vague. For a triple A, an um, abdominal aortic aneurysm, um, we're going to see things like back pain, flank pain. Um, they're going to have abdominal pain. They're going to feel full. Um, Nausea. They might have some shock-like symptoms like hypotension, tachycardia, and they might actually be able to feel like a pulsating abdominal mass in there. Education for this is we want to keep blood pressure is well controlled. We don't want their blood pressure spiking because that will cause a rupture. All right. I'm going to take a quick break, check on my kiddo because I'm not exactly sure what she's doing, and I will be right back. All right, moving on to valve disorders. So valve regurgitation or valve insufficiency, basically this valve is not closing tightly, and blood will back up. The workload of the heart's increased, and the chamber before the valve will actually cause that to atrophy. Stenosis is narrowing of the valve opening. Like when it's open, um, if it's supposed to be like an inch in diameter, it's only going to be open maybe half an inch, or it's only half an inch diameter. It's not opening properly. So the heart's also working harder to get blood pumped through that smaller hole. So anytime there's a smaller, the smaller the lumen of the valve opening or the vein or artery, the heart has to work harder. The larger the vein or opening, the less hard the heart has to work. Mitral valve prolapse. My slides must be. No, I don't have it. I don't know. Anyways, mitral valve prolapse. Let me look at me. Where it's coming from. The mitral valve allows backflow into the left atrium, causing that left atria to enlarge. So, symptoms that we are going to see with a mitral valve prolapse, we're going to hear a murmur. We're going to hear some of that regurgitation. You can hear the blood going where it's not supposed to be. Dizziness, they're going to be faint. They're going to be tired, short of breath. They're going to have anxiety. They're going to feel palpitations, and they're going to complain of chest pain. When that mitral valve is prolapsed and not working, we're going to see things like heart failure, pulmonary edema, and emboli, because the heart's not pumping effectively. Things we're going to see done are like an echocardiogram to look at the valves, and then maybe even a cardiac cath. Generally, mitral valve prolapses are not treated unless they're symptomatic. We're going to teach our patients no stimulants, no coffee. May have to have surgery for severe cases. They're going to be on anticoagulants so that there's not blood clots forming on that valve where it's not functioning properly, and beta blockers. So, going back up to signs and symptoms, the first sign that we are going to see in the case of a valve disorder or mitral valve prolapse, whatever it may be, is this murmur, because it's the blood rushing through the valves. All right, mitral stenosis. The mitral valve flaps and are thickened, and the chordae tendineae, which move the flaps, are shortened, so it actually causes a narrow of that mitral valve opening. Generally, mitral stenosis is caused by rheumatic heart disease or rheumatic fever. Like maybe they had it when they were a child and now they're having some of the symptoms as an adult. Complications caused by rheumatic. Um, the biggest issue with mitral stenosis is that instead of having a larger opening for that blood to flow through, it's got a smaller opening, so the blood flow is a lot slower. You can kind of see here. All right, so signs and symptoms of mitral stenosis. There's that murmur again. Because anytime there's issues with the valve, we're going to hear a murmur first. Then we're going to see some pulmonary symptoms like shortness of breath, cough, maybe hemoptysis, recurrent respiratory infections. You might see some pulmonary edema or palpitations, fatigue, complications that we might see with a mitral stenosis is an emboli, because the valves are not moving like they normally would, so they're kind of sitting still. So an emboli can form and travel. A thrombus can form and then start traveling, making it an emboli, and cause things like stroke, seizures, heart failure, dysrhythmia. Yeah, things that we're going to see to diagnose mitral stenosis is an echo and maybe an X-ray. More often than not, it's going to be an echo though. Again, no treatment if there's asymptomatic. Generally on anticoagulants because of the risk for blood clots. They might go into atrial fibrillation. They might go into heart failure. They might need what's called a valvuloplasty to go in and dilate that heart valve, done in the cath lab. And eventually they might need a mitral valve replacement. So then that leads us to mitral regurgitation. So basically the leaves or the flaps of the mitral valve are not closing correctly. So it's causing backflow into the left atrium. I feel like I just said that. Every time that left ventricle contracts, that's when the blood flow is going to go back into the left atrium. It mixes in with the blood coming in from the lungs, builds up pressure in the left atrium. That blood kind of pulls up in the left atrium, and then off to the right ventricle. And it can actually cause that right ventricle to fail because of the strain that it's causing on there. So things we're going to see, they're going to get short of breath with any exertion. They're going to be fatigued, dizzy, fainting type symptoms. They might have cough, edema, palpitations, and they're going to be weak from a decreased cardiac output. This is just a picture to look at. You guys can take a peek at it. Basically, the blood is leaking in the wrong direction. Again, we're going to see things like AFib, pulmonary hypertension, and heart failure with mitral regurgitation. Chest x-ray might be done. That'll show hypertrophy and maybe even enlargement of the left atrium. But then they're also going to do an echo. So things that we are going to do to help with mitral regurgitation. ACE inhibitors to reduce that afterload. Digoxin in case they have a fib. They're going to be an anticoagulant because we don't want them to throw a clot. And then they're also going to be treated for heart failure. All right, aortic stenosis. So when the left ventricle shunts blood into the aorta, it goes through the aortic valve. when this valve is um, obstructed or um, smaller than it should be, this is what aortic stenosis is. The narrowing, thickening, scarring, calcification um, of that aortic valve. Um, Eventually, that left ventricle is going to hypertrophy to keep working, to keep up the normal cardiac output, and it'll keep on like that till it can't do it anymore, and there'll be heart failure. So this picture really kind of shows what an open and a closed aortic valve is, and what an open and a closed stenosed valve is. All right. Signs and symptoms, we're going to see angina, because remember, angina is any time that the heart needs more oxygen that it's not getting. Um, we're going to hear a murmur, because again, it's an issue with one of the valves. They might be like kind of faintish because they've got decreased cardiac output, or maybe they've got AFib going on. Heart failure, and then orthopnea, when they lay flat, they have trouble breathing because of the fluid is shifting. So sometimes these people are going to need a valve replacement, um, but then they're also going to need to be treated for heart failure. Sorry, I gotta get a drink first. So aortic regurgitation is kind of the same thing, but we went over the valves. But basically, those flaps or those valves are scarred, thickened, shortened, um, and it's causing blood flow to go um, from the aorta into the left ventricle. Um, Eventually, the heart will give out, it will cause heart failure, decreased cardiac output, and pulmonary edema because it's not pumping effectively. Generally, you can see people can have this for a long time with no symptoms. First symptom we're going to see is murmur, chest pain, palpitations, fatigue, um, and then being short of breath with any activity. Keeping that down good. All right, so heart valve um, replacement can be mechanical or biological. Mechanical kind of creates this turbulent flow. You can actually hear it clicking when you listen to the heart rate. Turn it down. When you listen to the heart, you can hear it clicking. These people are going to be on lifelong anticoagulants. The other type is biological. It comes from another source of tissue. A lot of times I've seen them, they're like animal tissue. Can be pig, beef, I don't remember what all they use, but basically it comes from another animal, and there's a lot less risk of blood clot formation with a biological heart valve replacement than there is with the mechanical. All right. Oh, I had this. It was just in a different place. That's what I was looking for. Um, so rheumatic fever, or which causes carditis, um, is actually caused by group A beta hemolytic strep. Um, Generally, a person has a strep infection, and a couple years later, or a couple weeks later, I can't talk. Um, they may have this rheumatic fever. Generally, this happens in the teen years, or 5 to 15. Um, when the endocardium, like the inner part of the heart, is affected, that is the most serious, obviously, because it goes from the outside in. Um, but it can cause mitral valve dysfunction. And obviously, if it's affecting all of that, it can lead to heart failure. But basically, it starts out with a strep infection, and then that moves to the heart. Symptoms when they have carditis, all of the layers are inflamed of the heart. You might see things like polyarthritis, subcutaneous nodules, um, chest pain, shortness of breath, fever, rash. I know I talked to one of the students, and her mom had this as a child and was still going through treatment for it. But it's settled in her joints. Hope you don't mind if I'm sharing this. But it's really interesting, actually. And had been, sounds like she'd been doing a lot of treatment throughout the years. Um, throat cultures will be done to diagnose because it starts out as a strep infection. Penicillin is a treatment of choice. And then interventions after someone has had rheumatic fever, carditis, or a valve replacement. These people are going to be on prophylactic antibiotic therapy. So anytime they're going in to do procedures or dental work, they're going to be on an antibiotic. Infective endocarditis. Generally, this is when there's damaged or artificial valves, infection in the endocardium. It attaches, that bug attaches to the endocardium, where platelets and fibrins have formed like a lesion, so like a damaged valve. So basically, that lesion will cover the organism, protect the microbes, so that valve damage actually happens when these microbes that are covered by the lesion multiply. Eventually, they'll break off. They'll become a blood clot and travel. Bacteremia. Not sure what this part of it means. But anyways, you can see where they're attaching to the valves, the bugs are. Prevention for endocarditis. This is one of the conditions where if somebody has very bad teeth, they have an infection, it can actually travel to the heart, and this is what is caused. So if they have a cavity or a rotten tooth, that infection can travel down into the heart and cause endocarditis starting from a toothache. Best way to prevent it is oral care, dental care. Symptoms that we're going to see: fever, chills, heart murmur. They might have like muscle aches, petechiae. Complications that we could see from endocarditis obviously are emboli, because it's not going to be pumping effectively if it's inflamed. Heart failure, damage to those cardiac valves, abscesses because the infection is going to settle in the heart. We're going to see things like blood cultures, echo, CBC, chest x-rays to diagnose any of these infections. Generally, we're going to see them in the hospital for at least a short time, and then they might be on Vanco IV antibiotics for 4 to 6 weeks. Generally, they don't have to stay in the hospital for the entire time, but will be to start that out. Pericarditis is inflammation of the sac that holds the heart, the pericardium. Can be caused by other infections, drug reactions, rheumatic fever. Heart attacks can cause it, trauma, kidney disease. I want to say this is also one that can be caused by IV drug use, which I'm guessing both of them can, but I think pericarditis is more common. Correct me if I'm wrong, guys. All right, symptoms of pericarditis. They're going to be complaining of chest pain, dyspnea, fever, cough. Um, but the biggest, most telltale sign of pericarditis is the pericardial friction rub. This is the pericardium rubbing, the inflamed pericardium rubbing against the heart muscle tissue. So when the heart beats, you're going to hear it. It's synchronous with that heartbeat. So as the heart beats, um, the pericardium moves with it and grates against um, the heart muscle. You might also hear like a sharp, or might actually they might actually have a sharp, creaky, grating pain when they're breathing in, because they're going to be moving that pericardium over the heart muscle as well. Cough. Diagnostics we're going to see are CBC, looking for a white count, EKG to see how that heart's pumping, an echo to actually look at the heart, an MRI and a CT as well. Again, treatment's only if patient's unstable. Treat them with anti-inflammatory meds like steroids. They might need a pericardiocentesis, which is trying to get rid of some of that fluid. Sorry, my dog's screaming. And then we're going to have them on bed rest because we don't want their heart to work so hard. And then obviously NSAIDs. He must be barking at a squirrel or something. Are you done? Complications. They might have a pericardial effusion where there's a whole bunch of buildup of fluid in that pericardial space between the heart muscle tissue and the pericardium. It'll kind of muffle the heart tones, and this is when they're going to need that pericardiocentesis to get rid of that fluid. If that fluid is not taken off soon enough, we're going to see what's called cardiac tamponade. Now, if any of you guys have ever watched Grey's Anatomy, there's a few things that are like a recurring phenomenon in Grey's Anatomy. Happens once out of a million times in the normal hospital, but in Grey's Anatomy, it happens every other day. Cardiac tamponade is one. So basically, when there's all this fluid that's building up in that pericardial space between the heart and the pericardium, it's compressing the heart, and the heart isn't able to pump correctly, so it's just going to get mad and do whatever the hell it pleases. So obviously, we're going to see decreased cardiac output, increased heart rate. Not that it's effectively beating, but there will be an increased heart rate. They might be confused. They're going to have fast breathing, and they're going to be restless or anxious. Myocarditis is basically inflammation of that myocardium. Inflammation of that muscle tissue. It's destruction. To determine how severe it is, there's going to be muscle destruction and actually necrosis that will determine how severe this I can't talk, my God. Myocarditis is. It's very rare. Generally, it happens after a viral infection. There can be no symptoms, but it can be death would be the symptoms. Diagnostics, biopsy, echo, MRI. Treatment for myocarditis. We're going to look at what the cause of myocarditis is. So we're going to do things like antibiotics, anything we need to do to decrease that cardiac workload. We're going to put them on bed rest, limit their activity, treat heart failure. Other meds like beta blockers, ACE inhibitors, diuretics, digoxin. Yeah. Cardiomyopathy. I feel like we're just slamming these out here. Is basically the enlargement of the heart muscle. There's dilated, there's hypertrophic, and there's restrictive. There's no cure for cardiomyopathy. I went to school with a young man. I can't remember where exactly. He was a cop. Nacita, maybe? Um, but anyways, we graduated together. He married his high school sweetheart. Had, I think, 4 kids. And went to work one day and collapsed at work as a police officer. He had cardiomyopathy, which led to heart failure, which led to ischemia, which eventually led into a heart attack, and he was late 20s. Um, Diagnostics, we're going to see that enlarged heart on an x-ray. They might have an echo done or an MRI. The thing with the kid I graduated with, she had no symptoms up until then. So, dilated cardiomyopathy, as you can see in the picture, the ventricles are extremely dilated. Um, the ventricles increase, the size of the ventricles increase, but the cardiac output actually decreases. So because it's not able to contract as hard as it should, and blood pools in there as well. Let me see. There you go. Hypertrophic just means that the walls of the ventricles, especially, and the septum are much thicker. Can be hereditary. Um, that ventricle wall is so thick it becomes rigid and it can't fill as well and it can't pump as well. Restrictive cardiomyopathy, basically it's impairs the stretch and limits the filling, especially of the left ventricle. Um, it's not allowing it to expand so that it can fill easily. Oh, there's thrombophlebitis in my notes. All right, heart failure. Um, Heart failure is basically when the ventricles can't fill and they can't pump effectively enough to meet all of the body's oxygen, nutrient requirements. So there's a lot of things that go into heart failure. Um, Other disease processes can cause heart failure, like coronary artery disease, MIs, hypertension. Cardiomyopathy can cause heart failure. Valve problems. So basically everything we've already talked about today can lead to heart failure. Um, Heart failure can be left or right. And we'll get into it. Valve problems, backing up, valve problems that can lead to heart failure are things like we talked about, like the regurgitation and the prolapse. So generally the left side is the one to experience heart failure first, because the left side is the one that's pumping out. It's got the biggest job to get the blood out into the aorta and out throughout the body. So the left side works harder than the right, so the left side is generally the one that gives out first. I know we didn't talk a whole lot about labs. We did some labs, and I forgot the BNP. For heart failure, BNP is one of the most accurate tests to do to look and see the severity of the heart failure. Anything above 500 is considered abnormal, and I have seen people up in the 20, 30,000s. It's really crazy kind of lab. But you can tell generally, you can look at a person and determine that, yeah, their BNP is going to be way elevated. All right, so left left-sided heart failure. If you remember left L, um, left-sided heart failure generally affects the lungs first. So left L lungs. Um, because the blood is backing up from the left ventricle into the left atrium and then back into the pulmonary veins and then going to the lungs. So just remember that left-sided heart failure, lungs are affected first. Um, you're going to see things like increased pulmonary pressure, um, and they're not going to be able to have that gas exchange like they should. Most often than not, people with left-sided heart failure are going to have short of breath. They're going to be short of breath with any activity or with any exertion. Right-sided failure, since left-sided is lungs, right-sided usually affects the lower extremities. Uh, yeah, I think that's the best way to say it. Um, so biggest cause for right-sided heart failure is left-sided. So like I said, the left side works harder than the right side, so the left side will give out first, and when one side gives out, eventually the next side will follow. I don't want to say that it's never the right side then the left side, but more often than not, it is the left side then the right side. So basically, all the fluid is getting backed up into the systemic system. So we're going to see things like edema in the lower legs and in the abdomen. So anything, legs, abdomen, feet, anything south of the border. So here's just kind of a comparison to the side. So left-sided heart failure, you're going to see things, they're all kind of the same common causes, but with right side, it's generally left side failure is also another common cause. Symptoms of left sided heart failure, shortness of breath. You're going to see them, might be cyanotic. You're going to hear crackles in their lungs because they're going to have pulmonary edema. For right-sided heart failure, you're going to see things like JVD, like in this picture here, edema to the lower extremities, to the belly. Their abdominal organs might be affected, hepatomegaly. So you can kind of see where the difference is between the two. Goals for treating heart failure. We want that heart to pump better. We want to see what we can do about decreasing the oxygen demands. Obviously, we're going to treat the cause. We're going to talk to our patients about quality of life issues. Heart failure is a very debilitating disease, and it can really affect a lot of functions that a person does. And then we're going to look at acute versus chronic heart failure. Okay, now I'm going to pause because I go check and see what my mom is doing out in the kitchen because I snuck over to my mom's to record this lecture. So, yeah, we've only got maybe 20 slides left, not even, 10 slides left. So, I'm just going to take a quick break and then I will come back and we'll finish it up. All right, I'm back. I apologize. My mom had made lunch and was trying to tell me that lunch was ready without coming in here and telling me that it was ready. All right, so moving on to pulmonary edema. Pulmonary edema is also called acute heart failure. So it is this sudden severe fluid congestion in the alveoli in the lungs. So basically the lungs are filling up with fluid. Can be life-threatening. Sometimes it can happen with an MI. Basically, the heart is stressed and it's going to cause failure and it's going to fill up with fluid because it's not able to pump effectively. So the fluid's just building up and ending up in the lungs. The pressure builds up in the blood vessels of the lungs, moves into the interstitial space, leaks into the alveoli, and then therefore will reduce like the oxygen levels. So it can be caused by a number of things, acute events like a heart attack, or even fluid overload when somebody's on IV fluids and they're getting too much. Bless you. You're gonna see pulmonary edema. So symptoms of pulmonary edema, the classic symptom is pink frothy sputum. So they're going to have this fluid kind of, their spit is going to be pink and frothy. Generally, you're going to see an increased heart rate and blood pressure. Once the symptoms are worsening, the blood pressure will actually fall. So other symptoms that we're going to see with pulmonary edema are dyspnea. They're going to have trouble catching their breath. Orthopnea, where they're going to have problems catching their breath when they're laying flat. When you ask a patient, how many pillows do you sleep with at night? This is a big thing that will tell you if they've got orthopnea or not. So if they don't have issues with orthopnea, they're going to be like, oh, I lay flat with one pillow. Or if they do have orthopnea, they're going to say, yeah, I sleep with 3 pillows under my head because otherwise I can't catch my breath. You're going to see cyanosis of their fingers and their lips. They're going to be diaphoretic. They're going to be sweating. Obviously, the pink frothy sputum, like I talked about. And then you're going to hear that fluid in their lungs. You're going to hear crackles. So that is why it's so important when you guys are on clinical and when you get out there in the field. This is why one of the reasons why we assess lung sounds, especially on patients that have cardiac histories and that are on IV fluids. So our biggest treatment is to make sure that these patients aren't drowning in their own secretions, because they will fill up with fluid and basically drown to death. Diagnostics, here's the BNP that I talked about. BNP is for pulmonary edema, for congestive heart failure, basically the same thing where that fluid's building up in the lungs. BNP it's a B-type natriuretic peptide. The heart makes this to try and regulate the blood volume to reduce the work of the heart. When the heart is working overtime, it's not able to release, or it's releasing more BNP to try and get the blood volume down. So that's why anything over 500 in a BNP, generally rule of thumb, BNP 500 and above, depending on which one it is abnormal. You're going to see things like a chest x-ray, and then they also might do a CBC, BUN, and electrolytes. Therapeutic measures for pulmonary edema, we're gonna put them on oxygen, because with all that fluid, they're not able to keep their oxygen stats up like normal. We're gonna try and restrict their activity because we don't want their heart working any harder, because the harder it works, the less it functions. Control their sodium intake and their water intake. The more sodium they take in, the more water they'll hold on to. So if you remember, water follows salt. So the more sodium they take in, the more fluid they're going to hold on to. And then they're going to be on things like ACE inhibitors, ARBs, beta blockers, diuretics, and inotropics. So the ACE inhibitor is going to help with vasodilation. The ARBs are going to inhibit the RAA syndrome, I can't say it, the RAA system. The beta blockers are going to help with the sympathetic nervous system. Diuretics are going to get rid of that fluid, and the inotropics are going to also help with getting rid of some of that fluid. An example is spironolactone. All right, moving on to congenital and pediatric heart defects. So, congenital heart disease can be anything that's a defect in the heart, the vessels, or a fetal structure that continues on, that should be closing, like the foramen valley and all of that. Causes for congenital heart disease can be viruses, mom's metabolic disorders, genetics. Some types of meds can cause it, chromosome abnormalities. So, treatments, corrective or palliative, depending on the type. Um, and it also depends on the um, it's fine, it's just the alarm. Um, their culture, their religious affiliation might affect it too. We had a baby who was in the Amish community, and their feelings are that if God wants a person, that He will take them. It depends on how strict they are with this when it comes to what sect they are in or what area they're in. Julie Everson does a lot with the Amish and knows a lot more than I do, but I really enjoy working with the Amish. I think they're an awesome community. Um, but they had a baby who was born with heart failure, and she kept. Can you go let the dog again? She kept filling up with fluid. Well, easy fix to that was to give her Lasix, but their thoughts is that they didn't need to intervene, so they didn't give baby Hannah her Lasix, and she eventually went into cardiac arrest, and they lost her. But that was because the Amish culture, religious sect, did not agree with treating heroically. Um, Heart diseases that kids might get are rheumatic heart disease. We kind of went over that a little bit. If you guys have listened to Pam's lecture, I think she goes a little bit deeper than I do. Put down. They might get endocarditis or infective endocarditis, um, or even Kawasaki disease. So moving on to tetralogy of Fallot. So in tetralogy, um, you're going to see there's going to be a ventricular septal defect. So there's going to be a hole in the wall that separates the two ventricles. So the blood from the right ventricle is going to mix with the blood from the left ventricle. You can see where this is a problem because right ventricle blood is not oxygenated, whereas the left ventricle blood is. They're going to have pulmonary valve stenosis. Their aorta is actually going to be misplaced. It's shifted to the right. And again, it's going to receive blood from both ventricles. So it's mixing the oxygenated and the deoxygenated blood together. And then the right ventricle is going to be it's going to have some hypertrophy. So you can see where all of this, all four of these issues, is going to be a problem for these kids. So normal heart pumping, they're going to be releasing this completely oxygenated blood out to the rest of the body. But in TET, the blood is not going to be as oxygenated as it should be. So you're going to see things like their skin's going to be cyanotic, they're going to be short of breath, they're going to be fainting because they don't have the oxygen out to where they need to. They're going to have clubbing of their fingers and their toes, might have poor weight gain. They actually tire or fatigue very easily. They're going to be irritable, and because there are issues with the valves, they're going to have a murmur. So these kids actually have what's called TET spells. So like when they're feeding, crying, or even agitated, you're going to see their lips, their nails, their skin are all going to be very cyanotic because this is a rapid drop in their oxygen levels. If they're crying, they're not breathing in like they normally would to get oxygen, and then so it's not oxygenating even half as much as it normally would. So these kids honestly have this instinct that when they're having issues or tet spells, they're going to squat because somehow, and I don't understand the science behind it, but it works, um, to increase the blood flow to the lungs to get more oxygen to their bodies. And once the oxygen levels come up, um, they'll be back onto whatever they're doing. But they will squat and kind of get the, jeez, dogs are terrible. Will squat and try and get blood flow increased to their lungs. Um, Pediatrics in general, cardiac output is basically dependent on their heart rate until they're 5. Anytime that they have fever, they're stressed, exercising, respiratory distress, their cardiac output needs will increase. If it doesn't correct, their cardiac output will actually decrease. If a child has any uncorrected heart defects or unnoticed heart defects, eventually they will end up, about 90% of them will end up with heart failure. And bradycardia is a bad sign in kids. So those of you who are in my clinicals, when I had the boys and ended up shipping them out, Waylon was the first baby to get shipped out with HIB, but his sign was that his pulse was below 60. I never asked Morgan how low it actually got, but if their heart rate if they've got bradycardia, that is not a good thing. In babies, anything under 60 is cause to start CPR. So trying to keep making sure that is not dropping is a big, huge point. So just remember, bradycardia is not good in the kiddos. And then Pam put a little thing. Thank you for taking good care of me. All right, so this is it. I will get this loaded, and you guys have a wonderful day, okay? All right.